if someone had such a deficiency, they would experience pain where perhaps you wouldn't expect it. And everything would be too intense, light too bright, noise too loud. And there could be a whole bunch of manifestations: body pain, head pain. And I thought of conditions where this would fit. And again, the big three were migraine, fibromyalgia, and irritable bowel syndrome. And they really have a lot in common. These are three conditions that are characterized by what's called hyperalgesia, which is medicalese for saying too much pain. None of them have any demonstrable tissue pathology. If you look at the tissues, they hurt, but you can't see anything that's wrong with them in terms of inflammatory response, etc. They tend to occur in the same individuals. They're all what are called diagnoses of exclusion, meaning that you go in with this complaint, you get a bunch of tests done, and when nothing shows up, they say you have one of these three conditions, or God forbid, all three.
Hello, and welcome back to the Smarter Not Harder podcast, your go-to source for 1 cent solutions to $64,000 questions. I'm your host, Jodi Duval, and today we embark on an extraordinary journey into the realm of cannabis with none other than the Dr. Ethan Russo, a distinguished neurologist and psychopharmacology researcher. Dr. Russo has dedicated over 2 decades to unraveling the mysteries of the endocannabinoid system and the therapeutic potential of cannabis. With a background as the senior medical advisor to GW Pharmaceuticals and currently serving as the director of research and development at the International Cannabis and Cannabinoids Institute, Dr. Russo's contributions have shaped the landscape of cannabis science. His research, spanning over 50 peer-reviewed papers, dives into lesser-known cannabinoids like CBG, CBC, and terpenes, pushing the boundaries of our understanding. In this episode, we're set to explore Dr. Russo's journey into the world of cannabis, his groundbreaking work on endocannabinoid deficiency, and the evolution of cannabis research since the 1990s. We'll touch on his recent insights into industry challenges, product quality, and the ever-evolving landscape of cannabis-based medicine. Get ready for an in-depth conversation with a true pioneer. All right, Ethan Russo, it is an absolute pleasure to have you on, and that is an understatement for me today. So thank you so much for your time, and I welcome you to the Smarter Not Harder podcast.
Well, thank you so much.
So, Ethan, I want to discover what brought you to the wonderful world of cannabis. And I just want to know your turning point, your interest in cannabis, and what really and how your relationship has evolved with cannabis so far.
Sure. So, as a teenager, I was interested in medicinal plants. Really showing my age now. There was a guy called Ewell Gibbons who eventually did commercials for grape nuts, saying that they reminded him of the taste of wild hickory nuts. But he really was interested in herbs and what they could do. And it was something that I occasionally applied, like when I got a rash in college, I tried some of his things. But beyond that, I had a pretty standard medical education. Although when I was younger, I had a real interest in research. Once I got the neurology bug at about age 19, which is a bit unusual, it was pretty much straight and narrow through my training, grad school, medical school, and residency. So that brought us up to about 1990. I'd been in practice for 7 years, and I was really, really unhappy with the kind of results that I was getting, treating patients with increasingly toxic drugs with less and less benefit. So I really turned back to this interest in medicinal plants. My initial focus was on migraine treatment, and I had been aware that throughout history, there'd been a lot of herbal treatments, but I wanted to dig in on what the experts were using. And by that, I mean the indigenous people of Amazonia. So I embarked on an intensive study of what was going on there. And eventually it led to a brief trip to Peru to the rainforest in 1994, and then an extended trip. Whereas most people take a sabbatical at the university, I took mine in the University of the Amazon jungle with the Machiguenga tribe in Peru. And so I was primarily interested in their treatments for headaches, but also psychoactives in general, of which there were many. But it was a tremendous experience seeing how these people had adapted to life in a hostile environment where basically their food, their shelter, their clothing, everything came from the forest. And although we tend to classify such people as primitive, they were geniuses in their own right in their adaptations to this difficult place. I dare say that most Westerners thrust in the rainforest wouldn't last 3 days, trying to figure out what to eat and not poison themselves or getting eaten by bugs or whatever the problem might be, and they were formidable.
I know.
Sure. And I sort of knew at that point I was hoping to transition my career from strictly medical practice into research. But when I got back, it was 1996. And that was the year that Prop 215 in California legalized cannabis for medicinal purposes. And I quickly became thrust into the controversy about cannabis, which is a great thing, though, because I was really taken and fascinated with the depth of cannabis science and the endocannabinoid system and what it meant to our individual functioning, how we work, but also the medicinal possibilities. And in the course of that, I tried to do research through standard measures applying to the U.S. federal government for permission to study cannabis and migraine, and was thwarted at every turn. But the more I was thwarted, the more I wanted to do it. And in 1998, I published my first paper on cannabis, which got the notice of Jeffrey Guy at GW Pharmaceuticals. So that's the British company that got permission from the British Home Office to investigate cannabis and develop it as a pharmaceutical. Then, while I was still in practice and writing, I had a consultancy with them for 5 years, which then in 2003 turned into a full-time job for the next 11 years in the development programs for Sativex and Epidiolex, which to date are the only pharmaceutical cannabis-based medicines. So, I mean, that's it, briefly speaking.
It's an incredible start. Wow, Peru blows me away. Amazing. And your writing, Ethan, is such a pleasure to read. I must say, I've read a lot of your work extensively, and it's a work of art. So thank you. And I'm speaking for many here. I hear it. I hear this all the time. So thank you so much for your writing.
Well, it's a work of love. Writing's tough. Anybody who's tried, I think you really have to be in the mood. And when I have a task, I need to wait until I'm really excited about it. The drudgery aspect, you have to put aside and really take it on when the time is propitious and the feeling's right. Then it tends to flow, and invariably the quality is going to be a lot better. So if there are budding writers out there, that's the advice I'd offer.
Absolutely. The passion will come through. So now your work with the endocannabinoid system, the clinical endocannabinoid deficiency, I really want to start here. Now, so back in 2008, I believe, we're starting to talk about this. And I want to ask firstly how it was received back then, and where are we now with this clinical endocannabinoid deficiency? I find this fascinating. It's obviously a system that reaches across most of the body, I would say, in most areas, bar a few. And this is an incredible area that I want you to run us through, and then we can dive into a little bit more about that after.
Sure. Well, actually, it goes back a little further. I first wrote about this in a case history in 2001 on basically about a person who had migraine, fibromyalgia, and irritable bowel syndrome. And I surmised then that where cannabis helped, I surmised that all three of these things could be related and could be related to what I call the clinical endocannabinoid deficiency. So the reasoning behind it was the following. As a neurologist, I was quite aware that many of the things that neurology treats have to do with neurotransmitter deficiencies. So on a very simplistic level, when someone has dementia or Alzheimer's disease, they suffer from a dearth of acetylcholine, the memory molecule. In Parkinson's disease, we know there's an underactivity of dopamine. And although it's much more complicated than that, in depression, it's been related to a deficiency of serotonin. So given that the endocannabinoid system had been discovered, the question was, how would it be clinically manifest if someone had a deficiency of anandamide and 2-arachidonoglycerol, these endogenous molecules that resemble in their function THC? And among other things, if someone had such a deficiency, they would experience pain where perhaps you wouldn't expect it. Everything would be too intense, light too bright, noise too loud. And there could be a whole bunch of manifestations, body pain, head pain. And I thought of conditions where this would fit. And again, the big three were migraine, fibromyalgia, and irritable bowel syndrome. And they really have a lot in common. These are three conditions that are characterized by what's called hyperalgesia, which is medicalese for saying too much pain. None of them have any demonstrable tissue pathology. If you look at the tissues, they hurt, but you can't see anything that's wrong with them in terms of inflammatory response, etc. They tend to occur in the same individuals. They're all what are called diagnoses of exclusion, meaning that you go in with this complaint, you get a bunch of tests done, and when nothing shows up, they say you have one of these three conditions, or God forbid, all three. Now, they're all more common in women. They all have been, if somebody has all three, chances are it's a young woman who's going to be diagnosed by a male physician as having a psychosomatic disorder, or what more fancily is called somatization disorder. I don't think there is any such thing. It all comes down to biochemistry. And the, again, hypothesis was that folks that are so afflicted have a clinical endocannabinoid deficiency. But there are lots of other diseases that could fit. There are a few that will probably never be able to study or prove, like infantile colic. But certainly in the interim, since the first time I dealt with this in depth was in 2004. In 2016, I published a paper in follow-up, and I was able to show that there was a lot of support in the interim. But initially, this was funny. Doctors were skeptical of the concept, but I sure heard from a lot of patients who said, oh, you've got it, and this really resonated with a lot of people. I had an inkling that I might be onto something when my younger brother, who's a gastroenterologist, said, I think you really might be onto something here. So that was a bit of a coup. But I mean, I'll give a couple of examples that support the idea. One was a few years after the 2004 article, a group in Italy did a study I had suggested, but wouldn't be able to do in the States because of ethics committee problems. But the idea was to show deficiencies of the endocannabinoids in migraine. And they did this by doing lumbar punctures, spinal taps on, believe it or not just migraine people, but normal people, and showed this remarkable difference. The migraineurs having this deficiency of anandamide. So, I mean, that's objective evidence right there. Similarly, there was an excellent study by Matt Hill and his group showing that in people who had been in the 9/11 disaster, who'd been exposed to that, they had two groups, those that were there and didn't end up with post-traumatic stress, and those who did have post-traumatic stress after this terrible event. And they were able to show in serum blood samples that the folks who had post-traumatic stress were deficient in endocannabinoid function. So again, there's been a lot of corroboration. Similar things have been shown in multiple sclerosis, in autistic spectrum disorder, severely affected kids, and it goes on and on. The original study has been cited a couple of hundred times now in the literature. So I think there are people that believe it. And I was hoping, my fondest hope was that this would offer legitimacy to the endocannabinoid system as a target for therapeutics, and also really take the pressure off people that were affected by this, who had been told by one ignorant doctor or another that it's all in your head. Of course it is, but not in the sense that they were trying to convey.
Absolutely. So there's a few things that I want to follow on from that, Ethan, is that firstly, markers of endocannabinoid dysfunction. And I know this is one of your things that you're doing now. But following on from that, obviously, when we have a deficiency, is there such a thing as an endocannabinoid excess?
Yeah, no, that's well established, and it would be most operative in folks with type 2 diabetes or the metabolic syndrome. So that's an example where it's been demonstrated that there's too much endocannabinoid function, and it's manifest. It leads to a whole host of problems, including obesity, disturbances in lipid values, et cetera, and from there leads to all kinds of other problems related to blood pressure, risk of strokes, heart attacks, et cetera. So in treating it, one of the efforts was to try and knock down the endocannabinoid tone. And the drug that was initially approved in Europe for that was called rimonabant, previously known as SR14716A, by the Sanofi company. That's a sad story in every respect. A lot of us had warned the company and the medical community in general that, hey, this is a drug that it's too powerful. It's what's known as an inverse agonist. So it takes the endocannabinoid system as a whole and knocks the function down. So yeah, that would curb your appetite and you'd lose weight, but you would also likely be nauseated. You could develop new tumors. You could be more likely to have a seizure, become epileptic, and a number of these things happened. The main one that led to the drug's withdrawal was an increase in depression, anxiety, and suicidality. Now, as a result of this, and I would point out that was a synthetic. This was not something from cannabis. It was taking what we had learned from cannabis in the endocannabinoid system and trying to apply it in a synthetic drug that was way too encompassing in what it did. However, that set back the field many years, particularly in that particular area, but related to cannabinoids in general. We're still feeling this today, even though it's been like 15 years. Anyway, that's a long-winded answer to your simple question.
So just, for my clinical mind, obviously endocannabinoid deficiency in my small practice here, I've definitely seen correlations. And this is why I love how and why you write about this. But, so for those who are not aware, obviously you mentioned spinal fluid, but what other markers can we look at versus symptoms or exclusion for endocannabinoid dysfunction?
Right.
What are the that you're looking at the moment?
Well, I wish I could say it were easy, but it's not. You can look at serum levels, but it's fraught with difficulties. First, serum levels may not reflect levels in the brain where most of the action is. Secondly, when you're trying to analyze for endocannabinoids in the blood, the sample has to go under liquid nitrogen immediately because the chemicals are very unstable. So it's got to be frozen and gotten to a specialty lab. So it's difficult and expensive. Right now, we don't have great imaging for endocannabinoid function, short of doing PET scans, positron emission tomography, which is not widely available and very expensive. I think it's like a couple $1,000 a study. Just to do it because it involves radioactive reagents. And so there are some studies that have been done in this respect, but it's not a simple blood test or other analogous kind of investigation to figure out what somebody's tone is. So we do it clinically. We know that there are things beyond drugs that affect endocannabinoid function. And, one of the things I like to emphasize is working on lifestyle factors before resorting to drugs.
Mm-hmm. Yeah, absolutely. And obviously, when we're talking about the deficiency state or low tone of the endocannabinoid system, obviously we're looking at lifestyle, as you said, but also cannabinoids. And that's one of the things, obviously, you're using the treatment. Maybe we can explore that, and then I can go into the lesser known cannabinoids.
Sure.
So now I know you call CBG the mother of all cannabinoids. I did listen to your talk from CanMed in 23, start of the year here. And so there's a lot more minor or lesser known cannabinoids coming out onto the market and obviously being researched as well. Talk us through some of these exciting new or ones that haven't yet given the full fruition that they are deserved of.
Yeah, well, cannabigerol or CBG is one of my favorites, and it's been really under investigated heretofore for a couple of reasons. One is, even though we call it the mother of all cannabinoids, normally in the plant, it doesn't stop there. Cannabis is sort of a high throughput factory for other cannabinoids, particularly THC and CBD, and they hog all the attention. But in 2005, Etienne de Meyer, who also worked at GW Pharmaceuticals, developed a line of cannabis plants through standard Mendelian breeding. This wasn't genetic modification. He did it the hard way. And he developed plants that stopped at CBG. They didn't have the enzymatic equipment to go on to the others. So all of a sudden, there was a plant where 100% of the cannabinoid content was CBG. Unfortunately, things stopped there. The company was otherwise occupied with doing other stuff. And here was I saying, look, this is really important stuff. I knew that CBG had great potential medicinally in a number of very different areas. One would be as an anti-anxiety agent. Additionally, it works as an antagonist on what's called the TRPM8 receptor, which is important in prostate cancer, some breast cancers, and is very specific there. In 2008, it was shown that CBG is remarkably potent as a drug to kill MRSA, methicillin-resistant Staph aureus. So that's a bug that is responsible for serious and often fatal hospital-acquired infections. It sat around for a good while. Eventually, breeders in the United States Pacific Northwest got on to producing CBG-rich plants. And a couple of years ago, our group published the first real study in humans of CBG. So it was a survey. We insisted that people only talk about preparations that were at least 50% CBG. But we saw remarkable reports of benefit on, in particular, anxiety, depression, sleep, and pain. I mean, the reasons that people commonly use cannabis. Interestingly, almost universally, people thought that the CBG preparations were superior to conventional medicine. They reported very little, if any, side effects and no withdrawal if they happen to stop it. Subsequently, we're just completing, this is the first time I've talked about this publicly, another study, double-blind, done with interviews over Zoom of basically looking at CBG versus placebo and its effect on anxiety as done by testing. The results seem to be quite positive, and so we're excited to get this published. And I have often said what the world needs now is a non-sedating, non-addictive treatment for anxiety, and CBG is a great candidate, as well as these other things. Its ability to treat serious cancers without being toxic to normal cells, in contrast to standard chemotherapy, which is toxic in general. Great promise there. Also, on the antibiotic front, if we still have time on this topic, I will say that both of these latter things are being investigated by Andera Pharmaceuticals in Canada. And full disclosure, I'm chief medical officer for that company. But they're working on treating metastatic breast cancer, prostate, and lung to bone with lipid nanoparticles with some of these agents. Similarly, they have a wound care product that I hope will be on the market soon that combines cannabigerol with cannabichromine and silver. This is going to sound fantastic, but triple synergy between these agents that make it 186 million times more powerful in killing bugs than silver alone. And whereas cannabinoids normally only work on gram-positive bugs, these work on gram-negatives as well. So certainly for hospital-acquired infections, bad wounds, or burns, this is going to be revolutionary. So that's in the offing. I don't think it gets a lot more exciting than that. So shifting gears, also on the horizon, or it's really here, is THCV, tetrahydrocannabivarin. So this is an agent that normally is found in cannabis in small concentrations, particularly ones that come from Southern Africa. So it's like THC, but it's only got a 3-carbon side chain instead of 5. And the way it acts is really different. So if THC is an agonist, stimulates the CB1 receptor, this is a neutral antagonist. So in contrast to rimonabant, that's an inverse agonist of the CB1 receptor, this just sort of takes up space. So it's a much milder effect without the side effects of rimonabant at all. THC is THCV has already been tested in humans and been shown to allay hunger and improve lipid parameters in the metabolic syndrome. So will be very useful there. It also has pain-killing properties. It has some anticonvulsant properties. It is, in the States at least, beginning to appear in some preparations on the rec market, and people seem to like because of a reportedly clearer high. Again, great promise there. Others, CBDV, cannabidivarin, like its relative CBD, it has anticonvulsant properties, but in contrast to CBD that works on generalized seizures better, this works on focal seizures better. And the two together may be really have a broader spectrum of activity in treating epilepsy. So there's that. Then, just to put into context, we know the pharmacology of about 12 of the cannabinoids from cannabis, but there have been 150 different structures that the plant has produced so far. Every time one's been investigated, some wild and wonderful things come to light. There's also the acid cannabinoids. So these are the forms in the plant before it's heated. These would be THCA, tetrahydrocannabinolic acid, and CBDA, cannabidiolic acid. So THCA, although it was ignored for decades and called inactive, is not. It works on tumor necrosis factor alpha, which is a big deal in a variety of autoimmune conditions. It also works on PPAR gamma, a nuclear receptor that affects gene transcription and could be useful in cancer and pain conditions, or a real variety of things. CBDA, like CBD, works on serotonin 1A receptor, but it's between 100 and 1,000 times more potent. Although it really hasn't been tested this way, it may be a very powerful antiemetic agent for nausea and prospectively, again, treatment for anxiety. We know that CBD works for anxiety, but generally requires very high doses that, for the most part, are going to be impractical, at least from a cost standpoint. Again, work needs to be done there. But I think just from these few examples, you see the promise that's there. We've really only scratched the surface of what this plant can do for us therapeutically.
Absolutely. It is, as you say, exciting. The potential is huge, and we don't even know much yet.
Right.
Incredible. Thank you so much for sharing all that. So I want to move on, Ethan, to entourage effect, and that's something else that you write beautifully on. Obviously there is an ongoing suspicion of this, I believe. I'm not sure where we are at the moment. So what are the drivers for this, but also what is entourage effect? And when we're looking at whole versus singular, which we have been talking about here in the research, obviously the potential for medicine, for treatment, for disease state, for all these multitudes of things we've discussed so far. However, I know you are a big believer in the entourage. So let's talk through that a little bit.
Okay, first let me dispel a misconception. People think I coined this term. I did not. In 1998, Professors Mechoulam and Ben Shabbat described what they call the entourage effect in relation to endocannabinoids, so the cannabinoids within. And they noted that as in addition to anandamide and 2-arachidonyl glycerol, there were a bunch of related molecules that the body makes that seemingly are either inactive or don't do much on their own. But when they're around, they really potentiate the effects of the main players. So they called this the entourage effect. The next year, in 1999, they had an interesting statement that I seized upon because it confirmed something that I was already thinking. And that was the idea that in some instances, plants are better medicines than the single compounds derived from them. So this is really the concept of botanical medicine. But they went on to say that this is theoretical at that point. But in the intervening 24 years, we have a tremendous body of evidence that supports this. Now, I will say that this concept has a lot of detractors. In particular, there are a couple of studies done in Australia and New Zealand, by the way, that have been used as ammunition to say that there is no entourage effect. However, what they were looking at was the terpenoids, the aromatic components of cannabis, which I believe have strong benefits in cannabis therapeutics. The idea that they didn't work on the cannabinoid receptors. Well, that might be all well and good, but that's not the way they have to work to create synergy, a boosting of therapeutic effect. So again, people have overemphasized this negative finding without looking at the big picture, that these other substances do have medical benefits, and they may combine in a way that makes botanical, a drug derived from a plant, better than the single components. In my writing, I've given a lot of examples. Maybe we'll do one that's really pertinent. One of the early studies of Sativex in cancer pain looked at placebo versus a high THC extract versus the high THC extract with a high CBD extract, what currently is called Sativex. What happened was at the 2-week mark, treating hospice patients with intractable pain, not related to cancer, that was not responsive to opioid treatment. The placebo and high THC extract were about equivalent. They really didn't cause a big improvement. However, there was a 30% improvement with Sativex, the high THC and high CBD extract together. 30% improvement is considered highly significant to a pain patient. So the only difference was there was CBD in the Sativex as opposed to the high THC extract. Then there have been a wide variety of other studies that also support the concept. I would also point out, again, shameless promotion, the past few years, Ryan Vondre has headed a team at Johns Hopkins University in the States where we've looked at what I like to call a deconstruction reconstruction, looking at varying doses of THC with varying doses of terpenoids to show demonstrable effects on human functioning. So this is all done in lab, double blind. And again, we hope to have positive results that we've seen published soon. So my complaint is no amount of proof seems to be adequate for the detractors. So, at a certain point, they're trying to prove the negative, and we've already supplied the positive numerous times. I just don't know what's going to be sufficient for some of these folks. Anyway, in the end, it doesn't matter because people are buying cannabis-based preparations and they are using them to advantage. I can tell you that in our formulation work at Carito Science, we don't use single molecules. We try to have complex mixtures of cannabinoids and terpenoids, all with a rationale behind them to create better medicine. And the results have been very gratifying in terms of how they help people and are well tolerated. So yes, it can be done. One of the misconceptions about cannabis-based medicine is that it doesn't work if you're not high. I can tell you that the U.S. Food and Drug Administration considers being high a side effect. So we don't want that. I don't think it hurts, but it is not necessary to be high or intoxicated to have benefit on pain or other symptoms with a cannabis-based medicine.
Mm. And I think that has been well proven. And all of what you've spoken of so far is said exactly that. No need to have that. All right. So from here, that was beautiful. Thank you so much. I want to move on to round this out into the cannabis industry, the product, the synthesizing, the growing, the quality, the consistency, and even going into dosing, standardization, formulation. It's a big topic, I know, but I know it's something that you're very passionate about, as am I. What can be produced and given is determinant on what results you're going to get. So let's talk a little bit about that.
Sure. Well, here's where I get pessimistic. For better or worse, there are a lot of people in the cannabis industry that come to it from other directions, the entertainment industry, the real estate industry, and they think that their skills are translatable to cannabis production and making of medicine, and it simply is not the case. How to say this humbly? I've been doing this for 27 years and I'm still learning every day. So it's just not possible to transition from something unrelated and to understand the complexity of this plant and the system that it's treating and have it work. I would just tell anyone that thinks that they're about to corner the cannabidiol market and make a fortune that just don't go there. There's tons of the stuff around, so much that people are transmogrifying it into Delta 8 THC and other synthetics that really, with horrible quality control and potential toxicities. I'm a purist at heart. As much as possible, we like to stick to the plant in its natural state. Again, using selective breeding without genetic modification. But to grow this and make a medicine from it is really a tough business. It's easy to grow cannabis. It's very difficult to grow cannabis properly. Anyway, I mean, we could go on from here. It's a topic for hours in itself.
Such a complex, as you say, plant medicine, as well as the way that it interacts with the environment, from what I have read. So it's a very, very hard plant to get right, I believe. Yeah.
Sure. So, I mean, ideally, we'd love to grow it in the ground with regenerative agriculture. There is strong anecdotal evidence that when cannabis is grown in soil, supplying all that it really needs, that it produces a real diversity of components. So you won't just see THC and or CBD. You'll see a significant amounts of multiple cannabinoids and many terpenoids. And when people use this material, they tend to find it not only extremely tolerable, but very helpful for whatever they're treating. Again, how things are made from there, the techniques used to extract the medicine and produce it or increase the scale of production, all gets very complicated.
And so I know you talk about cryokeef as a technique that you have been using. So maybe just a brief overview of the complexity of this extraction or multiple extraction processes, and just to show the enormity of what we're looking at here.
Right. So the standard practice in cannabis culture is to grow the plant, cut flowers, and then dry and cure them. Now, this assumes that people are going to smoke or vaporize the product. What has happened in the course of this is that you lose up to half of the lower molecular weight monoterpenoids. So these are the things like limonene and pinene that give cannabis a lot of its scent. But it's not just about smell. These are both ingredients that have pronounced effects on our bodies and for good. Alpha-pinene reduces short-term memory impairment from THC. Limonene is a powerful antidepressant. Those are things that you typically want in your cannabis preparation. So the idea was, why not preserve these? And the way to do that is cut the flowers and immediately subject them to very low temperature with dry ice, solid CO2. And then the real medicinal part of the flowers is not the whole flower. It rather is what are called glandular trichomes. So these are things like a golf ball on a tee. You don't need the tee, you don't need the scaffold beneath it, you need the golf ball. And that's where the cannabinoids and terpenoids are produced. So when this is super cold and agitated, the trichomes can be filtered out, so they're isolated. In the process, you can basically triple the cannabinoid content and vastly increase the terpenoid content. You're also preserving the acid cannabinoids if you want them, or the material can be heated to produce the neutral cannabinoids, THC, CBD et al. So it really preserves what the plant produced. I see two possible directions to market for this kind of preparation. One would be for the high-end hash connoisseur. Someone wants the richest material without extraneous matter. And more importantly, would be for the pharmaceutical market, where again, without using solvents of any kind, you have the pure stuff that the plant produces in a concentrated fashion. So cryokeef, the process which we've trademarked, is just a refinement of an ancient technique of making hash. That's been pursued everywhere from Afghanistan to Morocco. So again, we have a lot to learn from what our human forebears already knew. Sometimes it needs to be rediscovered. And sometimes, again, we can add refinements to it.
Absolutely. I couldn't agree more. So Ethan, now right back to the beginning for you, I think, is in Peru. So now I want to move on to a little bit of a comparison as such into psychoactives of variations. So we're talking about obviously psilocybin coming into the market for therapeutic application. So where is your viewpoint there? Is there a market comparison with cannabis? So maybe some exploration of that now.
Yeah, a lot of common themes. I mean, aside from both being derived from forbidden drugs, psychedelics, I think a lot of these were derived from plants. And again, my whole research effort began with the prospect that plants and compounds that are psychedelic or hallucinogenic at high doses treat headaches at low doses. And that was the whole premise of my journey to Peru. Again, I had suggested a lot of this in early writing, but, it's coming to the fore again. However, I think the same mistake's being made. What we see now is that almost exclusively the research that's being done on psilocybin is with synthetic psilocybin as a single molecule, rather than looking at the mushrooms themselves, which contain other related compounds. Psilocin, baeocystin, these are again psychedelic in their own right. And I believe that the mushrooms have an entourage effect. Again, maybe a moot point, but to the extent that we'll be working with these situations, we prefer to work with extracts from plants rather than any synthetic compounds. So
Wonderful.
there's a lot to be done there.
Yeah, absolutely. And I believe the industry and the legalization and all the education surrounding this is also necessarily to expand before it starts to land in, the laps of consumers or those who we are treating. So I think that is also, just like cannabis, very similar. Yeah. All right. So Ethan, we don't have much time left. I have so much more to ask you, but I wanted to go towards, and I know you have touched on some of the most exciting things with cannabis at the moment, research, the minor cannabinoids. Talk to me about what future may look like. What are we aiming for? What excites you for the future? And it may not be anything that is in the forefront at the moment, but something that you're looking forward to.
Well, a number of things. Again, we're going to have continued problems with, efforts to legalize. It's just glacially slow. The problem is the rules are made, excuse me, by politicians, not by scientists or physicians. So that's part of the problem. I've mentioned some of the really exciting prospects for infectious disease and cancer treatment. We've got a whole host of other compounds from cannabis we haven't even touched on, like the flavonoids, canflavins, which have a remarkable anti-inflammatory profile without the risks of non-steroidal anti-inflammatories. So in other words, they don't cause ulcers, heart attacks, or strokes. Again, we're working with a Canadian company, Canurta, that is pursuing that. One of our efforts is to try to develop a pharmaceutical complex mixture from cannabis to treat amyotrophic lateral sclerosis, ALS, or motor neuron disease. So we're working on that as well. Then we've got the neglected areas. And the two biggest ones are cannabis in psychiatry and then cannabis in women's medicine. It's really, everyone has forgotten that among the indications that were most common when cannabis really took hold in British Isles and North America in the 19th century was treating obstetrics and gynecology. But this has been a forbidden area. There's still this myth that cannabis would be dangerous to women of childbearing age. But we know that it doesn't cause birth defects. There have been some studies claiming to show low birth weight in women who use it by smoking, but these invariably have been poorly controlled for other factors such as alcohol use, tobacco use, etc. Whereas we know in Rastafarian women smoking spliffs with huge amounts of THC that their children were not only normal, but advanced in their development. So
Wow.
Dr. Russo did not say that it's fine for women to smoke cannabis in pregnancy. However, what I am trying to say is in treating serious disorders like hyperemesis gravidarum, a severe form of morning sickness, cannabis can be life-saving, and it doesn't need to be used all the time. It can be used episodically, and there'll be no risk to the fetus whatsoever. It has pained me. I first wrote about cannabis and OBGYN back in 2002, and almost nothing has happened. So we hope to change that, and we're currently in discussions with a company that is interested in just that, getting cannabis into women's medicine. So not just hyperemesis gravidarum, but also endometriosis, menopausal associated symptoms. To me, it's just a crying shame that this hasn't been previously addressed.
Yeah, I was reading on multiple delivery methods for endometriosis just recently because I have multiple clients with that, and it's a horrible thing. And the pain management is extensive in the pharmaceutical realm. Why can't we go towards something that has a much better outcome, such as cannabis? But Ethan, is it more a ethical issue with research with women?
People claim that, but it's not justifiable on a scientific basis. So yeah, caution is always advisable, but it should not prevent the research and clinical trials from happening. Particularly with endometriosis, it's a complex disorder. On the one hand is the pain. Yes, we can treat pain and spasm very effectively with THC, but additionally, although it's not cancer, endometriosis has cancer-like properties in its ability to metastasize outside the uterus and affect the intestines or anything in the abdomen. We know that cannabidiol, mediated through what's called GPR 118, I think it is, has the ability to prevent this kind of spread of endometrial tissue. And just dealing with all the associated symptoms, I think we can do that in one cannabis-based preparation. It will not be a single molecule. It will be a botanical. But in context, prior to the last 75 years, basically all medicine was from plants. And we're still here. Some of it worked. And again, my friends in Peru in the rainforest, all their medicine, with a few exceptions, comes from the forest, and they have not only survived but thrived in most instances.
Absolutely. Now you're talking to a botanist. I have herbal medicine dispensary here, so I love all of the medicines associated with that. So no, it's absolutely 100% true. Thank you so much, Ethan. So I have one final question, and this can be taken two different ways, whichever way you want to take this. So we ask this to everyone who comes on, and we ask that you have 3 things that you live by to make your life smarter, not harder, or to optimize the endocannabinoid system to make it smarter, not harder. So you can take either direction here.
Well, yeah, I'm going to take the second one because it's easier. The first one requires a lot of thought for which I wasn't prepared. Okay, so yeah, I alluded to this earlier. What can one do to enhance your endocannabinoid system? So first is diet. This should be an anti-inflammatory diet, probably akin to the Mediterranean diet. So a lot of fruit and vegetables, olive oil, avoiding fried food, trans fats, all the stuff that would be indicative of a North American diet, which is bad. A lot of fermented foods, sprouted seeds, these kinds of things. Second would be moderate, not intensive, moderate aerobic activity. There is a sweet spot, which would be about 70% of someone's peak heart rate, whatever that is for age, where if you're in that zone, it's proven to boost endocannabinoid levels. And then the third one's really tickles me, and that is that singing boosts endocannabinoid levels. So I sang before this session today. So to wake me up a little bit and put me in a better frame of mind.
Incredible. Definitely the flow state and playing music. And we had a little quick chat about musical instruments just before, and it's a beautiful way to give that flow state. But now I know the endocannabinoid system too. So there we go. One and the same. I really, really appreciate your time today. Dr. Ethan Russo, it's been an absolute pleasure. And thank you so much for sharing here, but also all the work that you are doing. And it's from me and all the others, I can say, who are listening to this, and most people in the world, for your efforts with cannabis and bringing it to such the enormity that it deserves. So thank you.
My pleasure.
So until next time, thank you so much for coming on. Thank you for listening, and a heartfelt thank you to Dr. Ethan Russo for sharing his invaluable insights on cannabis, the endocannabinoid system, and the future of research and medicine. And if today's discussion has left you as intrigued as it has us, don't forget to leave us a 5-star review on your preferred podcast platform. Your support fuels our mission to bring knowledge to curious minds like yours. Stay tuned for more enlightening conversations on the Smarter Not Harder podcast. Until next time, stay curious.